A patient walks into your practice, sits down in the chair, and says those three dreaded words, "My eye hurts." Now, as a clinician, your mind should immediately start racing, because that complaint, well, it could mean a bit of surface dryness, maybe a minor corneal abrasion, or it could mean an absolute sight-threatening emergency. Welcome to this explainer for everything optometry. Today, we're decoding the painful eye, and I'm going to teach you how to assess these patients exactly like an experienced clinician does in a real-world clinic.
So ask yourself right now, would you know exactly which patient needs an immediate hospital referral and which one just needs some reassurance and eye drops? Listen, your job isn't just finding the root cause of the pain. Your actual job is recognizing dangerous eye pain immediately. We've got to figure out whether we're looking at a harmless ache, a sight-threatening condition like acute glaucoma, or a genuinely life-threatening emergency hiding behind what seems like a simple headache.
To do that, we're going to build a clinical diagnostic funnel. First, we'll become the eye pain detective. Then, we'll run through the suspect lineup. And finally, we'll tackle triaging and referral. Let's jump straight into part 1, the eye pain detective, because the most crucial part of your exam actually happens before you even touch the slit lamp.
Your history taking has to drive your diagnosis. You've got to sort the patient's pain into 3 distinct buckets. Ask yourself, does this pain originate from the eye itself? You know, like a gritty, surface-level dry eye, or maybe a deep aching iritis? Or is it an orbit issue involving the structures surrounding the eye? Or could it actually be referred pain stemming from the brain or nerves, like a cluster headache or a migraine? Getting these buckets right from the start saves you from going down the completely wrong diagnostic rabbit hole.
Okay, here is a massive clinical pearl, especially if you're revising for your exams. If your patient has absolutely none of these symptoms, meaning no visual loss, no binocular double vision, no bulging of the eye, a completely white eye, and absolutely no relative afferent pupillary defect, or RAPD, well, the eye itself is highly unlikely to be the source of the pain. If all of these red flags are absent, you need to start looking at non-ocular causes like sinus disease or nerve issues.
That means you have to ask the right questions. Did the pain start suddenly like a scratch or corneal abrasion, or was it gradual? Is it a sudden shooting, electric kind of pain? Because that points straight to trigeminal neuralgia. Do they have pain specifically when they move their eyes? That's a huge clue for optic neuropathy. And what if they report flashes of light, vertigo, limb weakness, or numbness? Guys, these are massive neurological red flags. Remember, transient causes often don't have visible ocular signs, so your history is literally your only clue.
And this brings us to an absolute non-negotiable rule. If the patient sitting in your chair is over 50 years old, you must ask about scalp tenderness, jaw ache when they chew, neck pain, and really profound fatigue. Why? Because you've got to rule out temporal arteritis, also known as giant cell arteritis. This is a massive red flag. Missing this doesn't just mean irreversible vision loss for the patient, it can literally be life-threatening. All right, moving on to part 2, the suspect lineup. Let's see how the clinical examination narrows down our culprits. This is absolutely key. Always assess the pupils. Look at the distorted, irregular pupil on the left there. That is a classic hallmark of iritis. Now compare it to the right. See that oval, mid-dilated pupil that just isn't responding to light? That screams acute glaucoma. Nailing your pupil exam right off the bat can literally divide your differential diagnosis in half in a matter of seconds.
If your history and pupil exam are pointing toward iritis, your slit lamp exam is going to confirm it. You're looking closely for fine details like endothelial carotic precipitates, those little dots stuck to the back of the cornea alongside aqueous flare in the anterior chamber. And here is your golden memory tip. Write this down. Pain plus photophobia plus a small or distorted pupil equals iritis until proven otherwise. Oh, and a quick caveat. If they wear contact lenses and present with these symptoms, you need to rule out a corneal ulcer immediately.
Now, let's talk about the painful eye every single optometrist must recognize instantly. Imagine a patient comes in with severe pain. They're seeing halos around lights, and they're nauseous or even vomiting. You look and see a hazy cornea, a closed angle, and their intraocular pressure is sitting way over 40. Let me be crystal clear here. This is not a review appointment. You do not ask them to come back next week to check how they're doing. This is acute angle closure glaucoma, and it is a drop-everything emergency.
Let's shift gears to the orbit. Imagine a child presents to your clinic with a severely swollen, red, incredibly painful eye, and a fever. You observe a droopy eyelid or ptosis and proptosis, where the eye is literally bulging forward. You might even find reduced eye movement and double vision. You are looking at orbital cellulitis.
This is a highly aggressive infection that can spread rapidly to the brain, making it both sight-threatening and life-threatening. But wait, a bulging eye doesn't always come with a raging, red-hot infection. If you see proptosis paired with a slow, progressive pain around the eye, it can indicate an orbital tumor. You might even notice a hyperoptic shift in their prescription because the mass is physically pushing on the back of the globe. This definitely requires urgent, fast-tracked investigation.
So the bottom line is do not forget your internal examination. Don't make the common rookie mistakes of forgetting to measure IOP, missing subtle pupil abnormalities, or completely skipping ocular motility. You have got to look at the optic disc. If you see an elevated, hyperemic, swollen optic disc with blurry margins, it gives you massive clues. It can explain the pain caused by orbital cellulitis or confirm an optic neuropathy. The internal exam is what bridges the gap between the patient's symptoms and your final diagnosis.
Finally, Part 3, Triaging and Referral. This is the most important part of your day. It's time to make the call.
You absolutely need to memorize this traffic light system for both your exams and your clinical practice. Is the IOP over 40? Acute glaucoma. That is a red, same-day emergency. Send them to the hospital right now. Temporal arteritis or orbital cellulitis? Also red, immediate life-threatening emergencies. What about a painful red eye with a distorted pupil? That's iritis. That's an orange, an urgent referral to be seen today. An orbital tumor sits at yellow, meaning a fast-track referral within 1 week. And totally normal ocular findings with facial pain? That's a green, routine referral for something like sinusitis or a migraine.
All right, let's finish up with a rapid-fire clinical challenge. Who gets seen today? Let's see if you've got this. Case 1, a painful red eye with photophobia and a small pupil. What is it? Right, iritis. Case 2, a contact lens wearer with a painful gritty eye. Suspect a corneal ulcer. Case 3, severe eye pain with nausea and seeing halos. Absolutely, acute angle closure glaucoma. Case 4, a painful, swollen, bulging eye with a fever. Orbital cellulitis, no doubt. Case 5, pain around the eye but totally normal ocular findings. You're likely looking at sinusitis or a migraine. So the very next time a patient sits in your chair and says, "My eye hurts," just remember, the history drives the diagnosis. Always assess the pupils, measure the IOP when appropriate, and never ignore photophobia. Every painful eye tells a story. And the real challenge isn't just finding the cause, it's being ready to make that confident, life-saving referral. Thanks so much for joining me on this explainer, and I'll catch you in the next one.